My name's Tom Powles. I'm a professor of oncology and director of Bart's Cancer Centre in London. The Volga Trial is a large randomised phase 3 study. It's in urothelial cancer. It's in muscle invasive urothelial cancer for those patients who are having a cystectomy. It's for those patients who are not eligible for cisplatin-based therapy. So there's a group of patients who have cystectomy alone. Those patients have a relapse rate somewhere in the region of 50%, and relapse of urothelial cancer we know is really bad. And what we're hoping to do is by giving a period of neoadjuvant therapy, adjuvant therapy, perioperative therapy, we can reduce the risk of relapse and indeed extend overall survival. So it's a large randomized phase 3 study. It's a 1-to-1 randomization. It's muscle invasive urothelial cancer, T2 to T4A, N1, M0 disease. It's urothelial cancer, predominantly urothelial tumors. Patients are going to receive a neoadjuvant triplet. This is ambitious. So they're going to get enfortumab vedotin, which is an antibody drug conjugate. It targets Nectin-4, MMAE is the payload. Enfortumab vedotin appears to be the most active antibody drug conjugate at the moment. We have others like sacituzumab govitecan, but enfortumab vedotin looks very active. We know it's active with immune therapy as well, so we're going to give it with immune therapy. Durvalumab, which is a PD-L1 inhibitor, and tremelimumab, which is a CTLA-4 inhibitor. So that's a neoadjuvant triplet that we're giving for approximately 12 weeks prior to cystectomy. The cystectomy then occurs, and then afterwards, patients are going to continue on durvalumab. Now, there are a couple of complicating issues. Number one is initially it's a 3-arm trial because we want to look at the component parts. So enfortumab vedotin with durvalumab is being tested as well. And of course, cystectomy alone is the standard of care. The trial's enrolling in over 100 sites around the world. It's already started. There's a safety run-in phase, which is currently ongoing, and then the 3-arm randomized phase 3 will then kick in. We think that not only is it going to be safe, but it should be very active. Reason why is enfortumab vedotin has got a lot of activity, 40% response rate in platinum refractory disease. When you give it with immune therapy, that goes up to 70% in the first line setting. And we know from the Danube trial and other studies that CTLA-4 probably increases your response rate by 10%. So we're hoping for pathological CR rates in the region of, I'd like 50 or 60%. I'd like to reduce the risk of relapse with the triplet by at least 30 or 40%. This is our ambition. And of course, in the end, we'd like to look at overall survival. Overall survival will be looked at, but the interim analyses, path-CR, progression-free or disease-free survival, will be also primary endpoints to make sure we're getting that initial disease control. It'll take, I hope, not too long to enroll. Obviously, we need hundreds of patients, and that's why it's a global trial. But it has a genuine chance of being practice-changing. It's the only triplet study in this setting, and indeed, one looks at these sorts of drugs, and I think they're the most cutting drugs available to us, or cutting classes of drugs, PD-L1, CTLA-4, and ADC. That's a really interesting question about other surrogate markers, because this field is moving really quickly. And so yes, of course, we'll look at path-CR, so that's obviously looking under the microscope and seeing if the cancer's disappeared completely. Chemotherapy is associated with a path-CR rate of about 35%. We know immune therapy is also associated with a path-CR rate of about the same, single agent immune therapy. So we'll look at that. Path-CR has never been strongly validated in this setting, which is why disease-free survival and overall survival are clearly super important to us, but there are other components which are relevant too. The first of which is circulating tumor DNA, and we're hoping to incorporate this into the trial. We know circulating tumor DNA, if positive, is associated with an increased risk of relapse, but we also importantly know that neoadjuvant therapy can clear ctDNA. And I hope in the future we'll not only use path-CR, but we'll incorporate ctDNA clearance into that. So ctDNA negative path-CR, I think, is a really good surrogate of a great outcome. One of the questions which we'd love to answer, but we're not directly answering in this study, is can we avoid cystectomy altogether? And there is some preliminary data showing chemotherapy and immune therapy can be given together, and it's possible using cystoscopy, but I hope also ctDNA in the future, that we can actually perhaps avoid cystectomy altogether. If we can get past CR rates in the region of 50 or 60%, or dare I say it, even higher, I think large groups of patients will say, do I need to go on and have my cystectomy? It's obviously a huge operation. I would like, within the next 10 years, I'd like us to stop doing cystectomies. And I know that's very controversial. But there are other approaches. Some patients, of course, will need a cystectomy. The drugs won't work. If we can identify the patients in whom the drugs work really well, put them into a pathological CR, ctDNA negative, and then observe them with time, we may be able to allow patients to keep hold of their bladders. We may even be able to avoid radiation therapy. The future steps of the Volga trial, it's a long and meandering river. I'm sure you're aware of that. And this trial will take time. We're currently going through the safety run-in phase. We've made great progress on that. We then need to launch the randomized phase. We need to see the component parts. That's why it's a 3-arm trial. And we will continue with the trial. There, of course, will be independent IDMC meetings to make sure it continues to be safe. But the next major step is to launch the randomized phase 3 part, not just the safety bit. And then, of course, to get the sites up and running as quickly as possible, because we're going to need to be enrolling patients very quickly. One of the key issues is around cisplatin ineligibility. You'll be aware that about 50% of patients are not able to have cisplatin-based therapy, and we need to identify those patients efficiently to make sure that they can take part in the study. Volga is a big randomized phase 3 trial. We're actually going to most of the world to take part. However, I'm sure there are sites within the countries that are taking part that would like to take part, and clearly that's a discussion that if you email me, I'd like to have that discussion, and we can always perhaps include additional sites. We're going to need a lot of sites to take part to make this trial successful.